Everybody. Let me first of all thank Dr. Hemant, who is actually the brainchild behind this whole program, and we're going to discuss about HBOC syndrome. We must thank AstraZeneca being our academic partner and getting Dr. Angela on board for us. So I'm sure that I don't need to spend too much time to introduce Dr. Angela George. She's with the Royal Marsden Hospital and she's an authority on this subject. So just to begin, why do we need to know about HBOC is because we know that the cancer incidence is increasing, and with good therapies that we have, today we have long-term cures and survivors, and therefore it becomes important for us to understand this, recognize that there is an entity like HBOC, and also this is going to help us to look at our own patient and to counsel the rest of the family. Because we know that BRCA 1 and 2 and several other oncogenes are responsible for the HBOC syndrome, and they are associated not just with breast and ovarian cancer, but several other cancers as well, including pancreas, melanoma, stomach, esophagus, and biliary tract cancers. And the other genes other than BRCA 1 and 2 that are involved are PTEN, P53, and several others. This is just to name a few. And we know that these are associated with several other syndromes. So it becomes even more important for us as medical oncologists dealing with these patients to understand the whole gamut of genes that are working in this disorder. And for us to understand this even better, we have none other than Dr. Angela George for us. One important thing that is, I'm sure she'll touch upon it, is the pre-implantation diagnosis. Diagnostics that are coming up in a big way, because with this we can actually detect the inheritance of these genes and try and look at solving the problems and implanting the fertilized ovum which don't have these inheritances. So with that as a brief introduction, let me call upon Dr. Angela George to take us through the interesting topic of HBOC syndrome. Dr. Angela, all yours.
Dr. Angela, can you hear us?
I think she has to unmute herself. Yes, there she is.
Dr. Angela?
So why can we not hear her, Kalpesh? Kalpesh, can you send a text message to her? And
I'm typing her. I am typing to.
Yeah. Yes. Her slides are coming up.
The audio is still not there.
I know. I think she has to unmute herself.
Dr. Angela?
Why can you not hear her?
I know. Okay.
So she's saying that she's not muted.
Muted. Yeah.
Kalpesh, आपकी तरफ से प्रॉब्लम तो नहीं है कोई?
No, sir, I have given full rights to her, sir.
So why can we not hear her? Dr. Angela, we can see your slide.
Yeah.
The third slide, it's not on show, but we can't hear you. Dr. Angela, we can't hear you. So Kalpesh, can you fix this? Talk to her. Maybe she can reconnect. I don't know what's going on, and we are wasting time.
Maybe she should disconnect and reconnect.
Yeah.
So I think so, sir. Suggestion. Let's move to the second one, and then.
Oh, she says she can hear us.
So Dr. Angela, we will try to fix the technical problem, and if you permit us, we will go to the second presentation. And in the meantime, we will see if we can fix your audio and video and then have you as the second speaker. Is that okay? Just, raise your hand like this.
Yeah, she says okay.
Okay.
Okay. So Hemant, you can introduce the next speaker.
Yeah, so I think our apologies for this technical glitch. Once in a while it happens, and we have our speaker trying to connect from several thousand kilometers away. So hopefully we'll be able to fix it, and we will be able to, enjoy Dr. Angela's talk sometimes down the line. We just switch speakers, and I'd like to invite Dr. Rima Pathak to give her talk. Rima is Associate Professor in Department of Radiation Oncology at the Tata Memorial Cancer Center. And she is actively involved with Dr. Rajiv Sarin and his group in hereditary breast and ovarian cancers in Tata Hospital. And they have one of the first genetic clinics, cancer genetic clinics in the country. And they're doing really sentinel work. So we would like to hear now Dr. Rima about the Indian scenario. So Rima, are you there? Your slides are up?
Yes.
Yeah, please go on. The floor is yours. The screen is yours now.
Thank you, sir. I'll just share the whole screen. Can you see my slides?
Yes, ma'am.
Yeah, we can see them. Go ahead.
Okay. So at the outset, I'd like to thank Dr. Sudeep Gupta and Dr. Hemant Malhotra for giving me this opportunity to talk on BRCA testing in hereditary breast and ovarian cancer syndrome, and especially talk about the Indian scenario. This topic is fairly close to my heart because I'm a breast oncologist, and this was my thesis as a postgraduate student, and now that I'm pursuing my PhD in cancer genetics, it's more so very relevant. So without wasting time, I have no conflicts of interest to declare. However, I would like to acknowledge that all the patient data that I'll be showing through these slides belongs to and has been generated by Professor Rajiv Sarin, as Dr. Malhotra rightly pointed out. And it also is work of the Cancer Genetics Clinic and the lab with chief contribution by Dr. Pradnya Kautal and Mr. Ravindra Reddy. Going on to the topic directly, who should be offered genetic testing? So as such, if genetic testing was not resource intensive, or it was not so expensive, or if it did not have any adverse impact on the psychosocial or the long-term functioning of that individual, then it would have just been easy to order it like a complete blood test. So you would have done it just like a CBC. However, we know that it is not that simple. It is resource intensive, extremely expensive, and it has implication. And hence, we have to select our patients. So we select patients who have higher likelihood of inherited predisposition to cancer. And traditionally, the cutoff that has been used is 10% of probability. However, that there is really no consensus. It could be 15%. It could be even 3% for some populations. It just depends on the risk perceived by the patient and by the physician. So also, there is no point of testing when there is no therapeutic or preventive option for that patient. So we go ahead with genetic testing where there are these options available. And by this cutoff criteria, nearly 10% of all cancer patients across all breast and ovarian cancers diagnosed would be eligible for counseling and testing. There are several mathematical models that have been built on thousands of patient data that tell us what the inherited predisposition would be and give us the risk prediction scores. However, the accuracy and validity of these models that were built on the Western patient data have to be closely monitored and evaluated in the Indian patient setting. And this was done again by the Sarin Sir's team. 521 HBOC cases were tested, who were tested for full BRCA1-2 sequencing along with MLPA whenever required, and pitted against the Bodesia and BRCA Pro model scores. And here it was seen that those patients that had lower risk score or lower probability of testing positive for germline mutation ended up having germline mutation positive in our Indian setup. And you can see almost a very, very large number of patients were observed when very small numbers were expected. That means here you can see that 47 patients tested positive out of 182, whereas only 6 were expected to test positive based on the BRCA Bodesia score. And similarly, here you can see in the BRCA Pro scoring as well, where only 4 were expected, nearly 62 out of 212 patients tested positive. And here you can see the odds ratio totally lopsided, and which just shows that even though these models predict that the patient does not have a very high risk of testing positive for any germline mutation, if there is syndromic diagnosis and for a experienced genetic counselor, if that counselor feels that no, needs to be tested, it may be more beneficial. And these mathematical models will have to be tweaked for the Indian scenario, or new models will have to be made so that we have more accurate data or more validated data for us to bank on. It also shows that there is a need for better guidelines in the Indian scenario. Coming to the criteria for testing, currently there are several guidelines and several testing criteria. However, I'd stick to NCCN and our own TMH criteria. Here I've just compared and contrasted for better understanding. The NCCN criteria are mostly built along the Western data where they have where all the models are built on. And it says that there is significant family history. If there's significant family history, you would select these patients for testing. And the same thing is there for our patient populations also. For most of the Western world, the breast cancer patients are screen detected and usually older than 60 years of age. And hence they have said that patients who are younger, so according to them, 50 years or younger, should be tested. However, for those who treat breast cancers know that in India, the median age of breast cancer patient is around 50 to 55. And by the NCCN criteria, nearly half our breast cancer patients would have to undergo counseling and testing, which becomes totally unwieldy and may not actually end up showing the results that we really seek. And that therefore the cutoff was arbitrarily reduced by 10 years to 40 years in our patient population. That means patients younger than 40 would be undergoing counseling and testing. Similarly, for TNBCs, where NCCN says younger than 60 years need to be tested, for our Indian population, we've kept a cutoff of 50 years. All ovarian cancers are recommended to undergo genetic counseling and testing, whereas in our scenario, if the patient does not have any family history of breast cancer, the lady has to be younger than 60 years to undergo genetic counseling or testing. There are several other criteria like bilateral breast cancer. If a patient previously had breast and then ovary, or ovary and then breast, then those undergo counseling and testing, or those with CA pancreas or family history of prostate cancer. Male breast cancer, and these are also reflected very well in the NCCN guidelines. Now, with those guidelines, this is what the growth of the cancer genetic services in Tata Hospital look like. Nearly 1,500 new families register every year now, and you can see the exponential rise in the demand of genetic services at Tata Hospital. And daily, the clinic sees nearly 5 new families and 10 follow-ups of the already registered patients or the healthy carriers. With this, and here we have almost gathered nearly 10,000 registrations on new families. And of these, nearly 9,000 families, we could make some or the other cancer predisposition syndrome. And you can see over here, most of these are hereditary breast and ovarian cancer syndromes. And this is merely a reflection of how the data is even worldwide. So HBOC or hereditary breast and ovarian cancer syndrome leads the germline mutation scenario far ahead compared to any other syndrome, even more so with the Lynch or Lee-Promeni syndrome. And you can see that the clinic caters to not just the HBOC, but malignancies that can affect someone from head to toe. These patients, not just the proband, but also the family members are counseled and encouraged for undergoing mutation testing. And here, this is the data shown for nearly 1,800 individuals in 1,100 families. And what is interesting to note that it literally follows the Mendelian rule, where nearly half of the family members, as you can see over here in pink, tests positive for the mutation, whereas the other half tests negative. And I always remember when Dr. Sareen shows this slide, he always emphasizes that it is not the mutation carriers that are diagnosed benefit largely from the testing, but it is the mutation negative relatives. That means a lot of these relatives that test or family members that test negative are finally relieved that they do not possess the deleterious mutation and can lead a normal life. So we also analyzed nearly 304 patients who tested positive for BRCA to look at what the phenotypic presentation was in these patients. And just like we spoke earlier, nearly majority or nearly half of them had unilateral breast cancer diagnosis, but a big chunk of them also had ovarian cancer. Some had breast plus ovary, whereas some had bilateral breast cancers also. If you further go into detail of the IHCs, BRCA1 is known to cause triple negative breast cancers, and as expected, nearly 85% of those who tested positive for BRCA and for whom we had receptor status known, they had triple negative breast cancer. So it does follow sort of the common standard that is seen worldwide and is not very different. Now, this is just a snapshot of trying to show what is the actual demand or what is the actual need of genetic testing in India. So in India, annually, nearly, it's predicted by Dr. Sareen that nearly 1 lakh cases may need BRCA testing, and I'm not talking about any other cancer, but just BRCA testing and counseling, even if the testing criteria is more stringent than NCCN. And he has come to this number as follows. So if we say that if we keep a stringent criteria and don't say that all ovarian cancers need testing, then at least 50% of all the ovarian cancers would require counseling and testing. That's 22,000. If we say that only about 20% of all our breast cancer patients will require testing and counseling, mind you, just the latest census that we took or just latest audit we made of our breast cancer patients at the Tata Memorial Hospital showed that nearly 25% of all our breast cancer patients are younger than 40 years of age. So I'm still taking a very, very conservative estimate because this was just an age cutoff, and yet I'm taking only 20%. So that brings us to 42,000. Now, if we take, so that brings us to a total of 64,000 patients. If we take only 1/3 of these 64,000 patients, then they are going to test positive for BRCA1 or 2 mutation. That means 21,000 patients or 21,000 families will have to be then screened. 1/5 of them, that means 1/5 of the 64,000 will get VUS in the NGS panel, and that we know is because of the rarity of testing in the Indian scenario. But luckily, the testing VUS rate has come down to about 15 to 20%, but it's still fairly high for that particular individual. Now, if we go and look at the number of family members that may have to be tested, nearly 40,000 relatives of them will have to undergo genetic counseling and testing. And by the Mendelian rule, out of these 40,000, 20,000 will be likely carriers. So, if you see the overall load of the testing and genetic counseling that is required, so even if this is typical of Dr. Sareen, and this is entirely his slide. So he says that even if by some magic, mainstreaming of genetic testing happens for most sporadic cancers or breast or ovarian cancers, still a detailed pre and post test genetic counseling is going to be required for 75,000 individuals. Because they might have strong family history, confirmed BRCA status, or VUS, or no identified mutation, but a strong family history. And this just brings us to the fact that the need is tremendous, and we don't know how we need to move forward. What happens if we don't screen these patients or don't screen the family members? This is what our own Indian data is, and not taken from any Western literature. This just shows for BRCA1 185 del AG what is the penetrance, and here you can see that by the age of 55, the chance of having developed a breast cancer is as high as 75%, and moving forward it goes up to nearly 85%. What about ovarian cancer? So by the age of 60, nearly 45% of these patients would have had ovarian cancer, and as you know, that ovarian cancer is not as yielding or as giving as the breast cancer, and is fairly dangerous. What is the state of genetic testing? We just spoke about the need, but are we ready? Do we know? Do we have the armamentarium? So in our country, the onus of medical decision making completely relies on the physician. Only if the physician orders, the genetic testing is done. And it's greatly influenced by the understanding of genetics by that physician and attitudes towards genetics. The awareness of patient is barely there in terms of genetic testing, and with time, when more and more targetable mutations are found, the demand will surpass the supply. And hence it's important to involve physicians in genetic testing and counseling for their seamless integration into care pathways. And this is precisely what mainstreaming is all about. This is a very important and seminal paper that shows what mainstreaming can do. And here you can see that the traditional BRCA testing pathway in UK initially for all ovarian cancers was once the cancer was detected, the patient would be discussed in a meeting and then referred. Once referred for genetic counseling, the patient will be counseled, then testing will be done, and then once results are done, then care will be personalized to the BRCA status. And you see over here, the patient loses nearly 20 weeks in receiving the appropriate therapy. And this happens because there is a long waiting period for genetic counseling and testing because of the sheer numbers of patients that require it and the dearth of counselors and testing facilities. What happens when there is mainstreaming of BRCA testing? That means the care physician or the oncologist who diagnoses and who tells the patient about or informs the patient about the diagnosis themselves are enabled to order BRCA testing after detailed counseling of that particular patient. And once the test is ordered, as usual, it takes around 4 weeks, 3 to 4 weeks for the test results to come in. And you can see over here that the care could be personalized according to the BRCA status in just about 4 to 6 weeks rather than 20 weeks. And for any oncologist who's here sitting knows the difference or knows the impact of the delay of these 16 weeks on the patient's outcome. So to test whether our systems are ready for mainstreaming, we wanted to do a KAP survey, that's the Knowledge, Attitude and Practice Survey among the oncologists for genetic counseling and testing, to recognize gaps in specific areas and provide means of designing strategies to mitigate. Here I will not go too much into detail. This survey was sent out to several oncologists throughout the country, and the typical type of questions were asked about several genetic syndromes. We will focus only on breast and ovarian over here, but I would just like you to focus on the type of questions we had asked. The first question usually was asked was dash to dash percentage of breast cancer patients may benefit from genetic testing. That means the lower bound and the upper bound interval was asked. And the other question was that other than strong family history, what were the other pathological or clinical features that may prompt them to consider for genetic counseling and testing? That means one had to recognize features of breast cancer other than family history for them to refer that patient to genetic services. And the same type of question was asked for ovarian as well. To know the attitudes and practices, we asked several other questions, and we also asked very, very pertinent and important question, practical oriented question as to what were the 4 most important causes why patients who may benefit from testing or counseling were not referred by them. And also, if they felt that there were knowledge gaps, how they could change their knowledge gaps or practice. And the one last question we added later and asked to them was about mainstreaming. So it was a direct question asking them whether they would like to participate if they were taught how to do a pre-test counseling or a simple post-test counseling, would they be interested in participating in mainstreaming? And this was pilot tested in some 75 participants or oncologists, and then subsequently was emailed throughout the country to several oncologists, and nearly 231 responses were there. So here you can see that most of the responses came from teaching hospitals, and the median years of experience was fair enough. It was nearly 8.5 years. Here you can see that most of them replied nearly 10 to 20% of breast and ovarian cancer patients would require genetic testing or counseling, which is not incorrect. However, here you can see the other clinical features in breast cancers where nearly 36% participants could not identify young age as the criteria. 60% could not identify triple negative breast cancer, and nearly the same number could not identify association with ovarian cancer for breast cancer patients, and nearly 85% did not answer about male breast cancer. Similarly, when we also asked about ovarian cancer, nearly 50% could not identify young age, 60% could not identify association with breast cancer, and a staggering 82% could not identify high-grade serous histology as one of the important pathological factors which would link or which could prompt genetic counseling and testing in patients with ovarian cancer. So we further went ahead and we had asked, what if the patient has a strong family history? How many percentage would need genetic counseling and genetic testing? And it was surprising and fairly shocking to know that even with a strong family history, they felt that only 52 to 72% will require genetic counseling, and a lower percentage would require testing, that is 42 or 44 to 62%. So it just shows that even in patients with strong family history, testing or counseling was not considered in 100% of these patients. When we asked about reasons for not referring, these were the most important results, as we knew that what we should base our further actions on when we want to spread awareness or we want to go down the mainstreaming pathway. So they said that yes, we were not aware, we had lack of physician awareness, lack of patient awareness, cost was one of the important criteria, lack of clear guidelines, and today we have the launch of Indian guidelines, and I'm extremely glad because that was one of the top 4 responses given by oncologists who felt that there was lack of clarity in guidelines, and they were clouded usually by the several Western guidelines that were probably not applicable to Indian scenario. And turnaround time for any treating oncologist waiting for a test for another 4 weeks might be fairly difficult, especially if it is an advanced cancer. We asked what were the suggested methods for improving the knowledge and practice, and that they came back with that you should incorporate it in training. So not just during postgraduate training, but maybe introduce cancer genetics or genetics per se at MBBS level, improve the availability of these services, conduct more workshops and CMEs or didactic lectures to inform oncologists and teach them about the importance and importance of the genetics facilities. So in summary, genetic counseling and testing demands will rise. Thousands of families suffer due to lack of physician awareness and financial constraints. The current infrastructure that we have is incapable of handling all the demand that is going to come in future. Mainstreaming may be the right way to go, and it has to be implemented in stepwise and planned manner. There are several challenges in practical implementations of the knowledge which needs to be addressed before attempting mainstreaming. We have to help generate Indian data by pooling of data for better prediction so that our VUS rates go down from 15% to probably 10% and 5%. Then strengthening overall infrastructure. So it's not just about testing and counseling or just repeated counseling with the geneticists, but it is also overall infrastructure, because all of these patients and their family members who are carriers will have to undergo screening. And it's a lifelong screening. So are we capable of handling that kind of load? And we have to improve social awareness so that there is reduced stigma and patients who are carriers also live without fear. Thank you.
Thank you, Dr. Rima. Yeah, go ahead, Hemant.
Please go ahead, Govind. Yours.
Thank you, Dr. Rima, for really throwing light on all the problems that we have in our country about this HBOC. And with this very purpose, I think Hemant will agree that ISMPO has started this initiative, and we've got Dr. Angela today to talk to us. And it was very nice that you gave us so much of data. And hopefully with this program, awareness amongst our oncologists will increase. Yes, Hemant?
Yeah, so I think we can invite Dr. Angela now for her talk, and we'll be wiser after it finishes, and then we'll bring out some practical problems facing all of us with this issue of HBOC in our country. Dr. Angela, the screen is yours.
Thank you very much. Can you see my slides okay?
Yes, we can hear you and we can see your slides. Please go ahead. Wonderful.
Perfect. Okay, wonderful. So thank you very much for inviting me to speak today. That was a really interesting talk, and I'm sorry about the technical difficulties to start. But I'm very excited to talk to you today about ovarian cancer genetics and how we have managed some of the setting up of mainstreaming in the UK. So just to remind everybody, most of our patients with ovarian cancer unfortunately present at stage 3 or 4. And certainly in the UK, where between 75 and 80% of our patients will be stage 3 or 4 at diagnosis. And despite our best efforts, around 80% of our patients will relapse and will ultimately die of their disease. When we look at ovarian cancer, it is a huge problem across the world. It is essentially the most deadly of the female reproductive organ cancers. But it is one which is potentially able to be targeted to reduce the rates and prevalence in the community, because around 15 to 20% of all of the ovarian cancers we see are caused by an underlying inherited gene alteration. And therefore, if we have the opportunity to identify those with ovarian cancer who have one of these underlying gene alterations, as well as making sure that we're giving them the best possible treatment, we also then have the possibility of preventing others in the community from developing cancer and over time reducing the burden of this cancer in the community. When you look at ovarian cancer, and any histopathologists will be aware that ovarian cancers under the microscope look very different, and we see clinically that the different subtypes of epithelial ovarian cancer behave very differently as well. Now, it's really clear when you start to undertake molecular profiling on these patients just how different they are. If we look at high-grade serous ovarian cancer, which is the most common of our epithelial cancers, can see that TP53 mutations are almost ubiquitous in the high-grade serous patients and routinely reported in between 95 and 99% of all high-grade serous ovarian cancers. We find BRCA1 and BRCA2 mutations in around another 20 to 22% of patients on tumour testing. And then they also have high frequencies of NF1, RB1, and the other HR repair gene defects. But this is very different when you look, for example, at the low-grade serous ovarian cancers, which look under the microscope much more akin to mucinous. We see KRAS, we see BRAF, and we see HER2 in both the low-grade serous and the mucinous patients. And of course, these patients are much less sensitive to chemotherapy. At the other end, we have the clear cells, which are predominantly driven by things such as ARID1A or loss of PTEN, which causes the same functional defect as ARID1A mutations. But we also start to see PIK3CA coming through in CTNNB1 as well. And finally, endometrioid, which is really a bit of a mixed bag of all of the others. We can see some BRCA1 mutations coming through there. We still see some ARID1A. We see a little bit of PTEN and PIK3CA. And in the high-grade endometrioids, we also actually see a small proportion of BRCA mutations as well. Now, in terms of the original genomic profiling was done, in the Cancer Genome Atlas work, they looked at the profiling of ovarian cancers, but the only ovarian cancers that they looked at were high-grade serous ovarian cancers. So most of the data that we have actually comes from studies such as this. So almost all of the tumours that have been profiled to date have been predominantly high-grade serous. And what we can see here is that of these, the BRCA1 and BRCA2, both germline and somatic mutations, are present in around about 20% of the patients. And then we start to see other defects in the HRD genes, which together make up almost 50% of the patients. So you can see that in a large proportion of our patients we have these potentially targetable mutations with drugs affecting the HRD system. Then you have a small number of those which are such as NMR, CCNE1, which may possibly cause some degree of HRD mutation, and then a whole host of other ones which are not involved in the HR pathway. But you can see with BRCA alone, we have about 20%, and HRD in total about 50%. And this is increasingly important for us when it comes to treating these patients. In terms of the ovarian cancer journey, this has changed quite a lot since I first started treating ovarian cancer, but some parts of it are still very much the same. We have the patients present with the symptoms of ovarian cancer, most of which tend to be stage 3 or stage 4. We confirm the diagnosis, we stage them, we undertake a biopsy. But what is different now is that we tend to get straight in with BRCA testing. Now, for us in the UK, we currently undertake germline and somatic testing in parallel, and I'll talk for the reasons about that in a little while. But essentially, as soon as the patients hit the oncology unit, they have germline BRCA mutations discussed with them, and as soon as we get a biopsy that confirms high-grade serous ovarian cancer, we send that off for tumour testing. And then the patient begins their first-line treatment. So in our unit, most of those with advanced disease, so 3C or 4, will start with neoadjuvant chemotherapy. Those below that will usually start with primary surgery and then have adjuvant chemotherapy. But it's really important when we start this that we know up front which sort of maintenance treatment we will be giving these patients. So for us, the earlier we get the BRCA results in, the sooner we know whether we would be giving these patients bevacizumab added into their chemotherapy or whether we would be giving them a PARP inhibitor at the end of treatment. So realistically, by the time the patient is having their first or second cycle of treatment, we need to know so that we can select the right treatment outcome for them. And then, of course, the other thing that has changed most recently has been the maintenance treatment at the end of first line. So up until about 18 months ago, if patients required maintenance treatment, they were given bevacizumab. But of course now for those with a BRCA mutation, either somatic or germline, we're able to offer them PARP inhibitor maintenance once they've finished their first line treatment based on the SOLO-1 study. So those patients who aren't suitable for maintenance treatment, either because they have contraindications or because they have an early stage of disease, will go back on to follow-up, and then at some point, of course, the patients will relapse. When we first set up mainstreaming, although we were keen to get testing done as quickly as possible in the patient pathway, it is fair to say that a lot of patients who were starting to relapse and had not been offered BRCA testing were suddenly being offered BRCA testing at this point. And again, this was about treatment outcomes. So at this point, we had maintenance PARP inhibitors available for those platinum-sensitive recurrence. So again, it was vital to get this testing done for the patients who previously missed out, so that we knew as soon as possible whether or not they were going to be suitable for that. And then we go obviously on to platinum-based chemotherapy, plus or minus Avastin if they're not going to be suitable for a PARP inhibitor. And then, but if they are, they then go on to maintenance PARP. Those without a BRCA mutation have their maintenance treatment with Avastin, and then those who don't require a maintenance treatment will go on to our active surveillance, and so on and so forth. So it is really important that we get that BRCA testing done as quickly as possible so that we can start to make the decisions as early as possible as to the optimal treatment. For us, although we could potentially start, for example, Avastin and then switch to Aliquot if the patient is found to have a mutation, it isn't an ideal way to do it. We only get one go with Avastin, so if we've already used it up for one cycle, that then means that the patient can't have it at a later date. So it feels like a bit of a waste to delay testing and then have a negative impact on the patient's treatment options. But it's also really important when we're having a discussion with patients about prognosis, and it's really important when we're talking to patients about the pattern of disease that they will get. And I've always said when I first started the mainstreaming program that almost every new ovarian cancer patient that I see asks me the same questions when they're first diagnosed. The first one is, do I need chemotherapy, and if so, will I lose my hair? The second one is, am I going to die from this? And the third question that they always ask is, what does this diagnosis mean for my mother/sister/daughter? And I would argue that all of these questions can be better answered by knowing upfront whether or not someone has a BRCA mutation. In terms of the implications, I'm able to tell my patients with a BRCA mutation that they are much likely to have a longer life and they are much likely to have better remission. They have longer responses to platinum-based chemotherapy and increasingly now have other treatment options which would not otherwise be available. In terms of family, of course, if we find a patient with a BRCA mutation, we are then also able to roll this testing out to their family members. And I have many family members where an initial BRCA test on someone with ovarian cancer has led to the early diagnosis of other family members with pre-malignant lesions or early breast cancers that we have picked up specifically because of a BRCA mutation in an ovarian cancer patient. And of course, this is helpful when we start to talk to patients about their likelihood of responding to chemotherapy, both in the first line and also in the second line. Having a BRCA mutation makes these patients much more sensitive to platinum chemotherapy. This diagram is from the ALSOP study, which was looking at patients who had a diagnosis of ovarian cancer and were tested irrespective of BRCA mutation status. They found across all patients with ovarian cancer, 12% had a BRCA mutation. And when they started to look at response to treatment, you can see that in the patients with a BRCA mutation who had their first relapse, 86% of them responded again to platinum if it had been more than 6 months. And you can see the sort of breakdown here in terms of how they were treated. Whereas the BRCA wild type patients who had been more than 6 months had a lower response rate at 68%. We always talk about patients who had less than 6 months before they relapse as potentially being platinum resistant. But you can see that in those who had less than 6 months before their first relapse, 15% of them still responded to platinum if they were BRCA mutation carriers. 31% of those who were BRCA wild type were platinum resistant when they first relapsed. So you can see that the chances of being someone who responds is much higher if you're a BRCA mutation carrier. And then, as well as platinum, we also most recently have all of the PARP inhibitors. So at this moment in time, we have access over here to 3 different PARP inhibitors. We have olaparib, based on evidence from SOLO 1, SOLO 2, and Study 19, which allows us to treat patients for first-line maintenance, platinum-sensitive relapse in the second or third line, and also with patients with pancreatic and prostate cancer with BRCA mutations. We have niraparib, which is currently able to be provided to patients with relapse disease as per the NOVA trial. And then we have rucaparib also for patients with platinum-sensitive relapse. And the striking thing about the 3 relapse studies is that you can almost superimpose the curves, and the hazard ratios are almost identical across the 3 studies, although the patient characteristics are very slightly different. SOLO 1, of course, is the only one which is currently licensed and approved in the first-line maintenance setting, and this was based on SOLO 1. Now, the really exciting thing about SOLO 1 is that patients who went into this study had first-line platinum-based chemotherapy, and then at the end of chemotherapy, if they'd had a partial or complete response, were able to start either olaparib or a PARP inhibitor. Sorry, olaparib or placebo. Patients who went into the study who were disease-free at 24 months this year were stopping the olaparib. But what you can see is that actually after that occurred, the curves don't come together. And we still don't have an actual progression-free survival because there are not enough patients on olaparib who have actually progressed at this point in time. So we are extremely hopeful that these patients who are all advanced patients, stage 3 and stage 4, probably have a high number of potential cures amongst them, which is something which we certainly wouldn't have envisaged several years ago. So this is really a game changer. Now, when we've been looking at who should be offered testing, traditionally genetic services offer genetic testing based on the family history. But actually family history is a really rubbish way of identifying who is going to have a mutation, because most of the studies of patients with ovarian cancer and a BRCA mutation show that between 40 and 50% of mutation carriers will not have any relevant family history. And this is particularly true of those who have inherited it through their father, because if a woman inherits a BRCA mutation from her mother, it is likely that her mother will have had breast or ovarian cancer herself, and people are much more likely to take notice. But if the mutation has been inherited through several generations of men, then there may not be very many women who have had the mutation who will show up with a cancer. And we see this also with our breast cancer study, where again we started offering testing based on age at diagnosis and histological subtype. And in fact, around 40% of those patients did not have a family history. So if you rely on family history to identify your ovarian cancer patients for testing, you will miss around half of the patients. So we now have a whole range of guidelines to support who should be offered BRCA testing with ovarian cancer. And these are based on the studies over the last few years that have shown how poor family history is as a marker of a mutation, and also as we've started to see more and more indications for treatment in those with a BRCA mutation. So the ISMPO and ISGO guidelines both state that testing for BRCA1 and BRCA2 is recommended for all patients with non-mucinous ovarian cancer. ASCO recommends that all patients with epithelial ovarian cancer should have germline testing for BRCA1 and BRCA2, and if they do not have a germline mutation, they should then have somatic testing, and that this should be carried out at the time of diagnosis, whilst SGO, the Society of Gynecology, have suggested BRCA testing for all patients with epithelial, ovarian, tubal and peritoneal cancers, even in the absence of family history. So all agreeing that family history should not be used to identify these patients, and ASCO going that one step further to say this should definitely be carried out at the time of diagnosis. But the earlier we pick this up, the earlier we can get on with treating the patients, and we can identify who should have what treatment. And this has probably been the biggest change that genetic services have had to get used to, because actually in the days gone by, genetic testing was carried out on people with cancer, not because it would have a particular influence on their cancer treatment, but because you wanted to inform the family whether or not they had a risk. And actually the idea that we would now start informing patients of treatment options based on testing has meant that the days of being able to wait 3 or 6 or 12 months for results is just not feasible anymore, because if you're doing this testing to aid treatment, you need to have it in a clinically feasible time frame. And the earlier you can pick this up, the earlier you can get on with giving the patient the best possible treatment, and the earlier you can identify her relatives with mutations and potentially stop them from developing cancer as well. So this has now been picked up by many people around the world. So again, we've had alterations to the ISMO and ESCO guidelines in 2017, suggesting this be undertaken at diagnosis. Australia put out national guidelines in 2015, which suggested testing should be carried out in diagnosis, although they were a bit more restrictive about who should have it. And ASCO, as you saw, coming in 2020, saying that this should be undertaken at diagnosis. Now, when we test for BRCA mutations, there are 2 main types of mutations that we can test for, and these do require different testing and have different implications. The germline mutations that we're all used to, which are the inherited ones, come from a parent present from the time of conception, and we usually test for in blood or saliva. But in particular in patients with ovarian cancer, around 5 to 7% of patients who do not have a germline mutation will have a somatic BRCA mutation. So these are not inheritable and are present only in the tumour, but are also relevant for treatment, because the studies such as SOLO-1, SOLO-2, Ariel and NOVA all included patients who had somatic mutations in their BRCA cohorts. And POWER1, which is one of the more recent ones, came out, which was looking at alacrib and bevacizumab, actually undertook HRD and BRCA testing on all the patients who went in for BRCA carriers. So this proportion of BRCA carriers is higher than we would see in the general population. And that's partly to do with how they set up the study. But again, if you look, you can see 29% of patients in POWER1 had a tumour BRCA mutation, and another 19% had a different type of HRD mutation. So again, just on 48%, around half of the patients in the study who were considered HR deficient. So somatic testing can certainly increase the number of patients who would benefit from PARP inhibitors over and above the germline testing. There was a study from the MD Anderson in Houston, which looked at just undertaking tumour testing on patients. They found 19% of patients had a BRCA1 or 2 mutation, and keep in mind that this will be a mixture of both germline and somatic. When they did subsequent testing, they found nearly 2/3 of them were germline and 40% of them were somatic only. So this shows you that by adding in somatic testing, you end up with a larger population of patients in which you found a mutation who could potentially then go on to treatment. So this is something that's been looked at a lot, and in fact there are a number of countries around the world, including those who often have more limited access to genetic counselling or more limited access to germline testing, who may opt to start off with tumour testing as a first screening test for the patients. And there's a range of reasons to do this, and also the fact that you don't need to take consent before you start this. So this involves taking a biopsy or undertaking upfront surgery, so primary debulking surgery, a core biopsy if they're inoperable, or taking it at interval debulking if you're starting with neoadjuvant treatment. It's really important how you fix the tumour. Fresh frozen or a DNA-friendly buffer is required, so a neutral formalin buffer. You need about 10 slides worth of tumour to get enough cells from this, and then you can undertake testing. So you need a pathologist who's on board because you can't have an overfixed tumour. You need a surgeon who's either going to, or an intervention radiologist to undertake your biopsies or to give you enough nice tumour on this. And you need someone who can run the testing for you. So it requires several people to be involved in the pathway. One of the questions that patients always ask, and one of the questions that clinicians have always been really keen to look at, is does it matter whether the patient has a germline or a somatic mutation in terms of their response to treatment? And we know that actually the patients with somatic mutations do better than those who are germline wild type, but slightly worse in terms of long-term survival than those with a germline BRCA mutation. But when it comes to their response to PARP inhibitors, they seem to be relatively equivalent. And I say this with the knowledge that actually in most of the studies, most BRCA carriers were germline rather than somatic. So in many of the studies, they weren't able to do subgroup analysis and look at this correctly. These are the ones that had decent numbers of the somatic BRCA. But for example, Solo 1 had only 2 somatic BRCA carriers and the rest were germline. So as far as we can tell, somatic mutations have similar PARP responses to germline, but we can't be 100% sure. So one option, as I said, that's been looked at by many places is to start with tumour and then look at germline. And there are pros and cons with both of these. So the thing to realise is that no matter which test you do, you will miss some patients. There are large deletions and duplications which make up between 10 and 15% of all inherited mutations with BRCA1 and BRCA2 in populations around the world that cannot be detected in tumour, and that's to do with fragmentation of tumour. So if you do tumour only, you will miss a proportion of your inherited BRCA carriers. If you only do germline, you'll miss that 5 to 7% of patients with a somatic mutation. So there isn't a perfect test. But by and large, if you start with somatic, you will pick up most of the germline as well as all of the somatic patients. So if you were only to do one test and you wanted to find the largest pool of patients with a treatment point of view, somatic is the way to go. If you're concentrating on finding the biggest number of germline carriers, then germline first would be the way to go. So two main methodologies that are used initially was Sanger sequencing. So Sanger sequencing was the gold standard until we developed next generation sequencing, but it is time and labour intensive and it sucks up a large amount of DNA. You need to undertake MLPA alongside Sanger sequencing to pick up large duplications and deletions, but you can do Sanger sequencing on either tumour or germline sampling. Next generation sequencing is now the way that we do most of our testing. It's high throughput, it's much cheaper, it's much faster. You do need bioinformatics people and it's more expensive to set up because most of the machines are more costly, but most certainly in the germline, you can detect large genome rearrangements with next generation sequencing, although not with tumour because of fragmentation. So, as I said, when you're setting up these sorts of pathways, there are lots of different people that you have to have buy-in and have to have involved. At some point, a patient needs to consent for this. Now, in our pathway, this is undertaken by some of the oncology team or the surgeon. But in many places, it will still be a genetic counsellor or a geneticist. If you're starting off with tumour, you need a pathologist who will prepare the tumour and get it reviewed, mark the slides and send it off for testing. When you're doing germline, you need someone to take the blood and prepare that. For both of these, you then need the preparation work in the laboratory, you need sequencing and the data analysis before somebody gets to a report at the other end. And along the way, this means that you have to have your oncology team, your surgeons, your pathologists, your geneticists, your scientists, your bioinformaticians, all involved to get to the end where you have a patient report or two. There are two different slightly different classification systems. Essentially, the main thing to realise is that each has class 3 or tier 3, which are variants of uncertain significance, which I was interested to hear about the rate in India. We see higher rates of VUS in all populations that have had less testing because many VUSs are ethnicity specific. And then you'll have pathogenic and likely pathogenic at both ends in terms of somatic and germline, and non-pathogenic or benign and likely benign at both ends of the germline and somatic one. So in terms of the recommendations, our recommendation is that patients should receive this testing as early as possible. So for us, that means diagnosis. We undertake this on all patients with invasive epithelial ovarian cancer. That includes fallopian tube and peritoneal. We don't take borderlines, mucinous or low grade because they're not BRCA-driven characters, and we undertake it on patients irrespective of age. For us, we do some somatic and germline in parallel, but this differs around the world. Some do somatic first then germline, others do germline first then somatic. But the testing should involve the full extent of BRCA1 and BRCA2 by a certified lab, including large rearrangements and deletions in the germline, and ideally this should be undertaken using next generation sequencing. And for us, we would anticipate a turnaround time of less than 4 weeks as being clinically relevant. There isn't a definitive way as to how you should do genetic counselling. This is also done by many different ways around the world. For us, this is predominantly undertaken by the treating clinician, but we still have some patients who go through this with genetic counsellors. But the problem with this is that there aren't very many of them, and there is often a long wait to see them. They're seeing their treating oncologist at the start and then every 3 weeks whilst they're on treatment, so it provides an excellent opportunity to undertake this testing, but you do need to train your clinicians, and the same is true of nurses. There have been several studies that have looked at alternative ways of delivering this, such as telephone testing or online. And again, this is cheaper than face-to-face genetic counselling, but you still need someone at the end of the telephone, and you also need patients to answer the phone. And unless they're locked down, that is sometimes quite difficult to have happen. So you've already seen some of the slides previously, but we set up our mainstreaming program back in 2012 and started delivering it in 2013. And what happens is that all of our patients with non-mucinous ovarian cancer come to their oncology appointment, they get given an information sheet, they have a chat with their treating clinician, and if they wish to go ahead, they sign consent and provide a blood sample. These results come back and are interpreted by the genetics team, and the patients and their clinician then receive the results, usually by mail. Those without a mutation do not need anything further. Those with a mutation or a VUS come to the genetics team within a week or two for further discussion and a discussion about how their family can access testing. We always left in this option, which was if a patient required additional information or had questions that the oncology clinician was not comfortable answering, they could still be referred to the genetics team. So we have tested, we've been running this for over 7 years. We run it as breast cancer as well as ovarian cancer, and we have now set it up in over 18 countries around the world as well as across the UK. I won't go through this one because this was discussed very nicely by Dr. Rima before, but just to say that based on our testing, this was also set up in Australia, and I helped them do this a few years ago. And again, they used a slightly different way of doing it by having a genetic counsellor embedded in the gynae oncology team who could then consent the patient when they came to clinic, and then have the patient receive the results from the specialist and be referred on to the genetic counsellor for further follow-up if the mutation was identified. It also worked well for them because they had enough genetic counsellors to be able to have someone sitting in clinic. Whereas I think we worked out that in order to have a genetic counsellor sitting in all of our ovarian and breast clinics at the Marsden, we would require an additional 7 genetic counsellors just to do that alone. So embedding a genetic counsellor can be used, but you have to have enough resources. So this does not work for those who don't have much in the way of access to genetic counsellors and for whom there is a long wait to see genetic counsellors, because actually it can be quite a waste of time to have a genetic counsellor sitting in a 4-hour clinic and only seeing 1 or 2 patients, particularly when there are long waiting times elsewhere. So just to finish off, testing ovarian cancer patients is vital, and we undertake testing of all of our ovarian cancer patients irrespective of age and family history. If you undertake the testing early on at diagnosis, it means you can use this information in all of your future decision making. Tumour testing is the only thing that will detect both germline and somatic, although keep in mind that you will miss a number of germline mutation carriers if you only undertake tumour testing. And of course, the main reason that we've seen rapid adoption of this, both around the UK and worldwide, is because of the PARP inhibitors moving into first and subsequent lines of treatment. So I'll stop at that point and thank you very much for listening.
Thank you, Dr. Angela, for that wonderful talk, for clearing many of our things as well. Yes, Hemant, go ahead.
Yeah. Thank you, Dr. Angela. I just wish that the audio was a little had a little bit of trouble in completely comprehending you. But thank you very much. Wonderful presentation, and I think we have about 350 people listening to this talk, and I'm sure that they must have really enjoyed. So to move the program forward, we will do a panel discussion now, and I'd like to share my slides with you. And okay, can you see my slides? Can you hear me?
Hemant, you're clear.
Yes, we can.
Okay,
Yeah.
good. So permit me to invite my panelists for this panel discussion. Dr. Angela George from Royal Marsden, London, has already been introduced to you. Pleasure to invite Dr. Sudeep Gupta. Dr. Sudeep Gupta is one of the foremost breast cancer medical oncologists in the country. He is a professor of medical oncology at the Tata Memorial Cancer Center in Mumbai. He is also the director of the ACTRAC institution at Mumbai, which is a part of the Tata Institute. Dr. Vinay Deshmane, very senior breast cancer surgeon trained in England. My very dear friend, we trained in oncology together. We have some very fond memories of the 10th floor of the Tata Memorial Cancer Center. Very happy to welcome Vinay. And Dr. Rima, you've already heard, she is Associate Professor Radiation Oncology at the Tata Hospital, and also very actively involved in the breast cancer genetic clinic at the Tata Hospital. Dr. Pramanik is Associate Professor in Medical Oncology at the prestigious All India Institute of Medical Sciences, New Delhi. And he is a very active contributor to the document which our president, Dr. Govind Babu, is going to release to you, the Indian consensus document on hereditary breast and ovarian cancer. Dr. Nikita Mehta is Associate Professor Medical Oncology at the Adyar Cancer Center in South India, Chennai. She's also a very active contributing member of this document. And in addition to being a very active clinician, she has a very active lab interest also, and she works in Dr. Rajkumar's lab. Dr. Aparna Dhar is a molecular pathologist par excellence, in charge of the molecular pathology laboratory at the core laboratories in Delhi, and she's also trained in genetic counseling. Dr. Priya Srinivas is Scientist F at the Cancer Department of the Rajiv Gandhi Institute of Biotechnology at Thiruvananthapuram, and she's had 15-20 years of laboratory experience in BRCA1, BRCA2 testing. So we have an illustrious panel. We have a surgeon, we have a top medical oncologist, we have radiation oncologists, we have a genetic counselor and a laboratory expert, and we have a hardcore scientist. So I think we should bring out some of the issues which we face in our country. So this is my institution. Welcome to this panel discussion and this program. And some of you will remember this cover of the Newsweek. You can see that this figure is a 59-year-old lady with breast cancer. Her daughter had a preventive mastectomy. Now the daughter's daughter, like this lady's granddaughter, is 5 years old. Now what to do with that patient? Should she be tested? Should you mess up her psychology right at teenage time? So these are some questions which still are looking, for which we are still looking for answers, and we'll see what consensus we can come to as we do the panel discussion. So all cancers arise from genes, but not all cancers are inherited. 80% of the breast cancers are sporadic. 20% are 15 to 20% of familial cancers, of which 5 to 10% there is a strong hereditary transmission. And if you could see here, 100 cases of breast cancer, 80 are sporadic, 10 to 15 are familial, and 5 to 10% are hereditary. And this is the difference between a sporadic cancer and a hereditary cancer. Higher risk of developing cancers in patients with hereditary cancers, younger age of onset, usually less than 50 years, and there can be multiple primary cancers. So let's do a case-based discussion. Let me present the first case capsule to you. This is regarding a patient with breast cancer with a strong family history. We have a 46-year-old premenopausal lady, educated, works in a bank, has dense breasts since adolescence, multiple cysts in the past, now noticed a new lump in the right upper quadrant. It's not going away, it's getting bigger, but she cannot feel any lumps in the axilla. She's been married for 21 years, has 3 children, 1 girl is 19 years old. She regularly self-examines her breast, gets a pap smear done every 2 years, past history of asthma, hypertension, but exercises regularly, and no history of tobacco, alcohol, and drugs. All the 3 kids were born after 25 years of age. First period at 11 years of age, and she has a history of cysts in her breast. There's a strong family history with this patient of ours. Her mother was diagnosed with breast cancer at age 45 in the premenopausal age, died at age 73 because of recurrence of the breast cancer. She has a sister who at age 40 has breast cancer. Paternal history, the patient's grandmother, as we call it, Nani, is diagnosed with breast cancer at early age. Patient's aunt, maternal auntie, we call it Masi, is diagnosed with CA ovary. And the paternal side, the patient's maternal uncle or mama has early onset cancer prostate. This is a mammogram 2 by 2.3, 2.9, 3.2 centimeters spiculated mass, few axillary lymph nodes. Ultrasound is a non-cystic mass. Biopsy is infiltrating duct carcinoma. The core biopsy is positive for the hormone receptors and negative for HER2. So an MRM is done. The pathological staging is T2N1M0. Again, ER/PR and positive, but HER2 negative. She receives standard adjuvant chemotherapy followed by radiotherapy and tamoxifen with LHRH agonist for 2 years. This is the family tree of the patient. This is our index patient. A sister who has breast cancer. Mother has breast cancer. One aunt has ovarian cancer, and in the earlier generation, again, there is history of breast cancer. So now this is an easy question. Let me ask Nikita this. Nikita, is genetic testing indicated in this patient? Nikita, can you unmute yourself and answer?
Yes, sir. Absolutely. She's a premenopausal. She's a young lady with an extremely strong positive, strong family history of breast cancer and prostate. There's absolutely no doubt that she does require genetic testing.
Yeah, so it is pretty ambiguous and pretty obvious to everybody, even somebody who's not initiated in breast cancer genetics, that this is a family in which there is some genetic predisposition is there, and this patient must be tested. So before testing, let me ask this to Dr. Aparna Dhar. Before testing and asking for genetic tests, is there something else which you should do and which you should do in all the patients? Aparna?
I think it's very, very important doing a pre-test genetic counseling. It is important that before a patient signs up for any type of genetic test, they do go in with informed consent, which means they understand why are they eligible for this testing. They need to understand that if they do come positive or they come negative, or even if they get a variant of uncertain significance, how is this applicable to them and to the rest of their family? So I think pre-test counseling is very, very important. You have to help address the patient's questions as to why they've been referred to your clinic, and also in doing so, in them understanding what their disease is, because genetic counseling is a communication process. So just explaining to them why their disease is and its repercussions for the rest of the family.
Yeah, I think that is very important, and that should be an extremely important take-home message for the people who are listening to this webinar, that just writing a genetic test, BRCA1, BRCA2 testing, germline, somatic, is not the way to go. Before you do that, you have to sit down with the patient. Either you sit down with the patient or refer the patient to an expert genetic counselor. And a pre-test counseling is absolutely vital. And this is the list of things which you have to cover in the pre-test counseling. I obviously don't have time to go through all this, but all this has to be on a form and has to be checklisted before you just simply prescribe testing for familial cancer or testing for BRCA1, BRCA2. This is absolutely vitally important. And I think this is becoming important enough, not only in breast cancer, not only in ovarian cancer, in all other cancers, this genetic predisposition is coming. And I think it is just a matter of time before it will be mandated, at least in cancer centers, maybe in all medical college hospitals, that there should be a person who is expert in genetic counseling. So this is a question, I think, is Dr. Sudeep Gupta on board? Sudeep, are you there?
I'm there, Dr. Malhotra, but my signals are very bad today, so I'm not sure. Can you hear me?
Yeah, we can hear you very clearly. So Dr. Sudeep, as one of the leading breast cancer experts in this country and dealing with these patients right and left, and having one of the best breast cancer genetic clinics in the country, if a patient like this comes to you, what tests would you prescribe for this patient?
Sorry, I got disconnected when you were presenting the case.
Okay, this is a patient, young immunopositive patient with breast cancer.
Yeah, maybe ask them.
Okay, maybe I'll ask Rima. Rima, you were there. You are in charge of one of the best breast cancer genetic clinics in the country. Maybe you have competition from Dr. Rajkumar's clinic at Dhar. What genetic tests would you ask for in this patient? Can you very clearly tell our listeners that what tests in this patient who has a very strong family history of cancer, what would you ask for? Rima?
So here we can typically say that she has a hereditary breast and ovarian cancer syndrome, because she has breast cancer on both sides of her family, and she also has prostate cancer in the family, and that too young. So we can probably order just a BRCA1, BRCA2 gene panel, but if that turns out to be negative, then a multi-gene panel NGS testing should be done. So whenever you're doing limited testing, you should tell the patient that there is a possibility, even though small, that the test results may be negative. And whenever we are doing only BRCA1 and BRCA2, MLPA testing also should be done with it, so that large genomic deletions are not missed.
Yeah. And you would do it on the you would do germline testing or somatic? Germline testing for inherited.
For knowing inherited mutation status, we would do germline.
And would you ask for an NGS or would you ask for a Sanger sequencing?
So NGS is obviously easier. We do Sanger sequencing as well at TMH. We do because it's it's not service oriented, it's more research oriented at our lab. We do something called as frequently found mutations. it's easier on the pocket. So based on geoethnicity of this patient, we would know that she may have a certain few mutations, and we would first test for those point mutations in these patients. And if those are negative, then go in for an NGS panel.
So, Raja, are you there? Dr. Raja Pramik, you work at a top institution of the country, the All India Institute at Delhi. What would be your approach? What are patients at AIIMS offered in this situation? Do you do an NGS? Do you do a Sanger? Do you also include MLPA to detect the large genetic deletions? What is the approach at AIIMS, Raja?
Yes, sir. So for this family, while I'm doing the pre-test counseling, I like to know whether, in view of this strong family history, has this test ever been done on this patient? First of all, because you showed in the pedigree that there is some mutations were detected. So if the mutation is already detected in the family beforehand, many years ago, then I like to go for this for single site testing. Otherwise, if it is a de novo proband, this proband has come for the first time and there is no testing in the family, then my test of choice is NGS multigene panel on the germline mutations. This panel will definitely include BRCA1 and 2 and a few of the other moderate penetrance genes as well, because the cost of testing is similar. And then and I asked the lab to do a reflexly LGR MLPA for large genomic deletions and duplications if the test for BRCA1 and 2 is negative. So it's already there for reflex testing. So NGS followed by reflex testing.
I think that's very, very clear, and I think that's very well said. I'd like to ask Dr. Priya. Priya, if you go back to the lab, how difficult it is to do BRCA testing? What are the practical problems which you encounter? Both for Sanger as well as NGS. Priya, are you there?
Yeah, I'm here. First of all, I just would like to make a comment on the other question, the first question about this particular patient. So, as far as we know, that you have already told, sir, from one parent side, the mutation is very specific. So, and the other parent side, there is a mutation in BRCA2. 7429. So just particular exon amplification will be enough, and then sequencing of that particular sequence, part of the gene amplification will be sufficient enough to identify the mutation in that particular patient, because she's carrying mutation from both sides, and we already know which mutation she is having. So the expense of doing the experiment, doing the analysis for that particular patient is very low compared to analyzing the whole gene with the next gen sequencing or Sanger sequencing, if at all. So mostly people now do Sanger sequencing, but in many companies they do particular exons. Maybe they select 4 or 5 exons. The problem here is that when we give samples for testing in these centers, they will look for certain hotspots only. So, for example, in Ashkenazi Jews, we have certain particular mutations. So they will be having those mutations into considering when they analyze them, they will analyze that particular mutation. And maybe 5 or 6 hotspots they will select and do amplification and analyze it, rather than going for a whole gene sequencing. So in that case, we miss out a lot of mutations. So that possibility is there in this particular case. But in my mind, as Dr. Angila was explaining, this is the case with hereditary breast ovarian cancers, but we have the rest of the sporadic population wherein they also have this BRCA1 gene mutation. So we have to consider that also. Yeah, that's my comment, sir. Thank you.
Aparna, you have a comment? You work at one of the really good labs in our country. Your opinion on this?
So I completely agree. The fact that if there is a known mutation, as it's shown in the family trait, then in that case, I do send it in for a basic mutation-specific testing, which is usually a Sanger sequencing to confirm that particular mutation. Only in the case when I don't know what the mutation is and there is a very strong family history as we have here in this particular case. Then in that one, I do send it for a multi-gene testing, a hereditary panel where we are looking at the main genes, at least the genes in the DNA damage repair pathway that are associated with hereditary breast and ovarian cancer. So cost-wise, it is the same. And I do like doing NGS plus MLPA simultaneously, just so that I get 100% gene coverage.
Okay, so let's move on. This patient opted for this was, she had an NGS done with a MLPA, and this showed up this class 2 mutation. Now my question to Dr. Vinay is that, Vinay, for a patient who has a strong family history and also a deleterious BRCA1 mutation, would you be comfortable in offering this patient breast conserving surgery, or would you insist for MRM? Vinay?
No, I would be quite comfortable in offering breast conserving surgery to the patient. Although there is a move towards BRCA patients not doing very well with breast conserving, that hasn't really been proven. So all of them don't really have to undergo a mastectomy.
So are you saying that it doesn't make any difference whether the patient has a BRCA mutation or not, family history or not?
I'm saying BRCA mutation doesn't contraindicate a breast conserving procedure.
Because then you will have to give this patient adjuvant radiotherapy.
Yes.
Is that controversy at rest now, that you can do that without any added risk?
More or less, the data has not shown that they do worse. Let's put it that way. So as long as we don't have definitive proof that this patient is going to do badly with a breast conservation, there is really no need to withhold a breast conserving procedure.
Right. And the second question is also to you. This is a patient who has a very strong family history. I mean, you can't have a strong family history stronger than this. So would you wait for the BRCA mutation to come before you decide the treatment? Suppose the patient says that she wants an MRM, or if she tells you that if I have a genetic problem, then I would prefer an MRM. Otherwise, you can go ahead with the breast cancer surgery. Would you wait for that 2-3 week period, or what would you do? What would be your...
I think what was discussed earlier, that is your pre-test counseling and discussion, is actually the most important aspect of this.
Yeah.
The patient needs to be told when we discuss breast conserving about the mastectomy, also about the controversy with radiation. All those things really have to be discussed. So this is going to be a long consultation. It's not one of those. You sometimes have to give the patient time. I, in fact, ask the patient also to read up on the net and come back, so that they are quite sure of the treatment that they're getting and they're convinced. Because if they take multiple opinions, as what happens in our country very often, then they are going to get differing opinions.
Yeah.
So a well-versed patient and well-educated patient is one of the best to treat. Once they are convinced that they are getting the right treatment, it's very easy to go ahead. Then you're discussing genetic testing. Counseling, as I said, is the most important, because we face a lot of difficulties actually in the clinic. And when you are in a breast center outside of a general hospital setting, patients have options. Now, luckily, the turnover for genetic testing is actually you can get them sometimes as low as 2 to 3 weeks. You can get a report today in Bombay. So, the turnaround time is if the patient is quite sure, after you counsel them about genetic testing, that they want a mastectomy, and you discuss a contralateral prophylactic mastectomy with or without reconstruction as per the patient's wants. If the patient is very keen, then I think you could wait. And especially with the ER positive tumor, if you feel worried, you could even put them on neoadjuvant testing treatment for that period if the patient is worried.
So can I ask Dr. Sudeep to come in? Sudeep, what is your personal preference for a patient who has a BRCA mutation and a strong family history? Are you comfortable with advising those patients? If the patient tells you that, sir, you decide for me, I can't make up my mind, then what would you be comfortable with the breast conserving surgery with radiation, or would you suggest MRM? Dr. Sudeep? Sudeep, are you there? Can you hear me? So I don't think Sudeep is there. Dr. Angela, what is the consensus in India now where I have no hesitation in saying that you're more advanced with regards to genetic counseling as compared to our country. Is this controversy addressed that giving radiation to these patients is not a problem? Dr. Angela?
Sure. So I'd actually agree with all the things that have been said so far. I think if we had a patient like this, the discussion would be had with them. Ideally, we would have the result before surgery, or if it came back after their primary surgery and they'd had a wide local excision, we would have a discussion with the patient about their options, either to go back and have a completion mastectomy and a contralateral risk-reducing mastectomy with reconstructions, or whether they go ahead with the planned radiation treatment and then have high-risk screening thereafter, which would be with annual MRIs and mammograms. And it varies hugely from patient to patient. We will have some patients who will want a surgical solution, who will be very clear in their mind, and we will have others who are very keen to avoid more extensive surgery and will be happy to continue with high-risk screening. So it's a very personal decision from patient to patient, but we would discuss both options with them.
All right, thank you. So, more than 2,600 mutations have been described in BRCA1, BRCA2, and there is a peculiar problem of, there are several other genes which are also involved in familial disease. Most of the times the transmission is autosomal dominant, so I think we've already talked about this. In the interest of time, I will go this. And I think this is important for our audience to know that if the patient has both BRCA1 and BRCA2 mutations, then the chances of developing breast cancer is between 50 to 85%, while as compared to the general population, it is only 11%. With BRCA1 mutation, the chances of and developing ovarian cancer is 40 to 60% by the age of 70, and slightly less if you have only the BRCA2 mutation. So I think we've already discussed this, so we can move forward. So this is a question I'd like to ask Raja. Raja, other than patients who have a strong family history of breast and ovarian cancer, which is the subgroup of patients who should be offered genetic testing?
Yes, sir. The consensus is very clear in the NCCN guidelines of who else should be offered this genetic testing. For the personal history of cancer, other than breast and ovarian, all metastatic pancreatic cancers should have genetic testing. All prostate cancers who are metastatic or locally advanced, or even early ones who have a high Gleason score or who have acinar histology, they should undergo genetic testing. And if there is a mutation detected in the family, already detected in the family, then all the first degree and secondary relatives are eligible for testing. And even if there is a patient in the family, is a close relative means first degree relative or second degree relative. If any of the first degree or second degree relatives have a personal history of cancer which merits testing, then that patient is also eligible for testing. These are the clear 4 points which are clarified in the NCCN guidelines, and we follow this.
Yeah, and very well said, Raja. And you will remember that when we were formulating our consensus document, I won't call it guidelines because of the reasons, we had this big issue of not kind of copying the NCCN guidelines, which is really wide and comprehensive, which has included all the cancers. In fact, it is so extensive that it appears that all cancers should have a genetic testing, which is not possible or feasible in our country. So these are some of the classical situations where you must have a testing done. And I think this is the list of the NCCN, and it's an ever-expanding list. Every year they add more into this, and I think very soon they'll say that every single patient who has cancer should have genetic testing. And we had a tough time in shortening down this list without really hardcore evidences from our country. And I think this is a question again which is of a lot of interest. Let me ask Rima this question. As already discussed with you, our patient has a 19-year-old daughter. Now, should this patient be offered genetic testing? And Dr. Rima?
Yeah, so typically, even with the BRCA1 and 2 mutation, the onset of cancer usually, so if you would have seen the cancer predisposition graphs that I had shown for the 185 del Ag of BRCA1 and BRCA2, the graph usually starts from 25 years of age. So till 25 years of age, rarely anyone, even with anticipation, will develop breast cancer, and ovarian cancer develops a little later anyway. So we wouldn't, I mean, we can discuss this option with the 19-year-old because she's an adult, but testing can be initiated, testing and screening can be initiated from the age of 25. If the 19-year-old is mature enough to take the decision and wants to get the testing done, then as an adult, we can offer testing to her.
So that is, I think, a pretty dicey question in deciding whether a 19-year-old has achieved maturity or not. The person is mature enough to vote, the person is mature enough to drink, the person is mature enough to drive. So I guess, I know it's an arbitrary cutoff. One 18-year-old would be able to understand everything, and one 18-year-old would get completely hysterical if you give them this information. So it's like a lot of tightrope walking to do, and then you have that whole bunch of psychological problems, and that is where genetic counseling comes in. So the psychological aspects and the trauma which you induce it has to be very, very carefully thought of and very, very carefully considered. So, Aparna, you are also a genetic counselor of note. Would you agree to this?
I do when it comes to anybody under the age, I know the NCCN says 18, but anybody under the age of 21, I get a little worried, irrespective if it's male or female, when it comes to doing the genetic counseling and recommending testing, because as you rightfully said, that while we may consider them to be an adult in taking decisions with voting and etc., but they can always rectify and change their mind with respect to those decisions. But we're taking a decision at the age of 18, 19 for something like genetic testing. I've seen both ends of the spectrum where sometimes it doesn't sit well with the children, and especially looking at our, looking at the Indian society per se. When you have a young 19-year-old girl who has a BRCA mutation, it can be considered a taboo because she's coming from that sort of that sort of a background. So at that young age, I would not. In this particular social setting, I'm not very comfortable. And no matter how tactful and how gentle a genetic counselor is in breaking that kind of information and however experienced you are, I do tend to feel that sometimes it could have major psychological implications, that even the slightest pain or the slightest fever and the child is thinking, what is suppose I'm going to get what my mother or my father or whoever has been, whatever cancer has been there in the family. So I get a little scared at that particular age, but they are adults. If they want to do it, I obviously can't stop them, but I do give them a bit of both sides, so they're aware before they make a decision.
So Vinay, what do you do in a situation like this?
I couldn't agree more with what was just said. I mean, we are completely in a different social this thing. Forget young children, even adults don't really want to know with a strong family history. I've been counseling for years. I mean, it started really in '95 with guys when we had a genetics clinic, and when I came back, I tried very hard to set up BRCA testing, which didn't happen in early 2000s. And of course now, it's quite easily available. But even then, I find families, even highly educated families, well-to-do families, don't want to undergo. If you counsel them, they don't want to undergo testing. They don't want to know. They don't want their children to know. There is a social taboo. There is social discrimination, whether you like it or not, in our society. There is difficulty in getting married, in finding a partner, acceptance. understanding of genetics in our society. And this is really something very, very important. That's why I feel when we discuss genetic testing, I think we should be discussing counseling. Counseling is really the way to go ahead with our society. And testing should be carried out in people who actually want it and are motivated. I have patients who have walked into clinic for a second opinion. They have a BRCA test which is positive. And I asked them, well, what have you decided to do about it? They say nothing. So I said, why did you do the test? They said, well, somebody told me to do the test. And that's how testing is being done in society today. So for a person who's so young, I mean, I think one has to be very, very gentle. And as I said, it's all, there may be some kids who are very, very precocious in our country who are quite ready for it and want to know. So in that small group, yes, I think you may follow whatever is mentioned really in the West. But I think you have to feel your way in our society with your patients and with their families.
Yeah. I think you have to individualize, and it's really, really difficult. I'm very happy not to get into this whole jumble of things, and I just refer the patient to my genetic counselor. I'm lucky enough to have one DM in medical genetics in my institution, and I just pass my problem on to her.
Yeah, Hemant, just to
I have a question.
Yeah, Hemant, just to say that for years I used to do my own counseling. For the last 2 years, I do have an in-house genetic counselor, and it has obviously decreased the load.
Yeah, it makes a big difference. Yes, please, go ahead.
So in this year's ASCO, there were 2 abstracts on this whole online pre-test counseling. One was on HBOC, and I think one was on prostate cancer with BRCA mutations. So I was wondering how many on the panel are actually willing. They were both positive. They were both in favor of these online counseling sessions. How many are actually in favor of it given the COVID situation, etc.?
Well, my genetic counselor is doing online counseling.
Okay.
As a routine.
You're comfortable with that, sir?
Yeah. What happened was she sits in my clinic with me, and now of course that's off. But even then, the first time she would talk to the patient or in the clinic, and thereafter most of the time it would actually be online.
Okay. Thank you.
Yeah, Aparna, one quick comment.
Yeah, I just want to add that we actually did a survey in India last year. We actually published in ASCO with my team, and with using telegenetics as a model for genetic counseling and actually transferring, this type of critical information. And patients are very, very receptive to it. The only caveat is that as long as you have somebody who's trained and understands the job and the profession, I don't think a patient suffers in that perspective. So the genetic counseling is carried out, and I don't want to say it's equal to a human touch, but even using telegenetics, it is a good model for, especially in today's situation.
Thank you.
Okay, I think I have such a learned panel that I could continue this panel discussion till 4 a.m. in the morning, but I don't think we'll be able to do that. Is Dr. Sudeep there? Sudeep, can you hear me? So I just wanted Sudeep's expert insight into this, and I will quickly move forward and see if we can.
The internet, so I can just keep it.
So I think I'll just go to my conclusion slide, and some other time we will do all this. And all of us are aware of this Angela effect. Does this happen in our country? Vinay, you are the surgeon.
Yeah, no, absolutely. Because I've been counseling since early 2000s when I started, and there was hardly any acceptance.
Right.
And I can really see, I just, every time when I discuss with somebody, I speak about this lady. And I think she's done wonders, at least in our society. She's done wonders for acceptance of genetic testing, genetic counseling, and bilateral prophylactic mastectomy and oophorectomy.
So she increased your business and you're happy?
Well, not my business, because I refer to the gynacs for these surgeries, except the bilateral mastectomies are still not very popular, I must admit. Bilateral mastectomies, at least in my whole in our society, are still not popular.
So I think I'll go to my conclusion slide. I had some more cases to discuss, but we don't have time for that. So this is the document which we've come up with a lot of hope. I'm sure this will have lots and lots of flaws and problems. And I'd like to thank three people especially who worked very hard on this, three top people, Dr. Sudeep Gupta, Dr. Rajkumar, and Dr. Rajiv Sarin. It was actually Dr. Rajiv Sarin's baby. And then the three people who work with them, Dr. Pragya from Dr. Rajiv's lab, Dr. Nikita from Dr. Rajkumar's lab, and Dr. Raja Pramik from AIMS. These three young people have worked very hard on this. I know I'm just there first because I just grabbed all the credit, but these are the guys who really did all the hard work. And this is my last slide. HBOC syndromes are not uncommon. Detailed family history and pedigree analysis are must. And it is not preferable but mandatory to involve genetic counseling and genetic counselors right at the first contact. And the patient requires intensive pre and post test counseling. And patient requires to know all the possible effects and results of the genetic testing. I find that the variants of unknown significance is particularly distressing both for the prescribing doctor, for the genetic counselor, and for the patient. They tell us that you asked us to spend several thousands of rupees, and now you're saying you don't know what to do with this. Am I going to get cancer? Am I not going to get cancer? I'm sure each one of you has your opinion on that, but I don't have time to hear those opinions. But this is a neglected field in our country. And I was very fascinated with the survey with Dr. Rima showed that there's a very large number of practicing oncologists, maybe medical, maybe surgical, maybe radiation, who are very less aware of this syndrome and what needs to be done in patients who have a family history. And I think more and more contact and more education and training is needed for a lot of people. And with that, I'd like to thank all the speakers and all the panelists for this wonderful interaction. I wish we had more time. So thank you very much. So with that, I'll stop sharing my slides and hand over proceedings to Dr. Govind Babu. Dr. Babu.
Thank you, Hemant. That was a nice panel discussion, and a lot of questions were answered and a lot of doubts were cleared. I think we have had a good session. And as an important medical oncology society, the ISMPO, we've taken it upon us to bring out this document. And we have done this for several other cancers as well. We brought out for head and neck cancer recently, for lung cancer. And this has been an important issue that was to be tackled. And I'm glad that we were able to bring this out. And all credit to Dr. Hemant, who was leading the whole team there. And it's my great privilege and honor to dedicate this consensus document to our society. I'm sure this is going to be of great help to all our members to fall back upon, because we know that we cannot in toto adopt the Western guidelines, as you have heard from both the speakers, what the pluses and the negatives are. And I think this document will fill in those gaps that we have and help the Indian oncologists to tackle this problem in a much better way. So thank you, Hemant, for the privilege that you've given.
Thank you, Dr. Govind Babu. We have a link which we can share with you. And you can access, this is a free access journal, the Journal of Global Oncology. And you can download this document from the JGO without any problem. And again, we come to the end of this webinar, and my most sincere thanks to, of course, the participants, Dr. Angelina, for an excellent talk and some very wonderful work, Dr. Rima. Great work being done at our own Tata Hospital in Bombay. And all my panelists, all my friends, and particularly my co-chair, Dr. Govind Babu, and all the people who have listened to this. Also would like to thank AstraZeneca for supporting this initiative. They were very helpful in getting the document ready and setting up a meeting also. And I'd like to thank the MICE IDEA teams, Mr. Rajesh, Neeldeep, Kalpesh, who were the back-end people and getting all this together. So thank you very much. Have a wonderful weekend. And this document, which we have shown to you, which our president, Dr. Govind Babu, has released and launched, this is a living document. We intend to look at it and revise it every year. So if you have any inputs, any suggestions, any comments, any criticisms, please feel free to email any one of the authors. Feel free to email me, Dr. Govind Babu, or our secretary, Dr. B.K. Smriti. And hopefully we'll be able to iron out the issues which we have with this document and come out with an even better document. And I'd like to request Dr. Vinay also to post the link of this document in the Indian Journal of Cancer so that more and more people have more and more access to this document. So with that, please permit me to end this webinar and have a wonderful weekend. And thank you again very, very much.
Thank you. Bye-bye.
Bye-bye.